Okay. All right. Well, good afternoon, everyone, and welcome to Pediatric Teaching today. This is a little bit different to what we've covered in the past. I mean, most of the topics we've covered have been um, uh, common illnesses. And 2 weeks ago, we talked about the interpretation of CT scans, particularly in relation to um, head CT scans and different sorts of brain injury or brain infections or brain pathology. I wanted today to focus on ultrasound particularly. We'll talk a bit about CT scans, but I wanted to focus on the diagnosis of abdominal tuberculosis, particularly with a focus on imaging. And because increasingly ultrasound is available in many hospitals, and you can get a lot of information from abdominal ultrasound. And I think it's within the remit of pediatricians to be able to do ultrasound scans to look for common pathologies. And it's possible to teach yourself about ultrasound, and it certainly shouldn't replace the clinical process for making diagnoses, but it can add to that. And I want to try to describe today how it can add to the diagnosis of abdominal TB. It doesn't replace the way we normally diagnose abdominal TB, but can add to it and can assist the diagnosis in a very good way, I think. So this is what we'll talk about today. And in the process of that, we haven't previously in the lectures talked much about ultrasound, but I'm going to try to explain some concepts of ultrasound, not too much, but explain the concepts of ultrasound as they apply particularly to the diagnosis of abdominal pathology and especially to the diagnosis of abdominal tuberculosis. So let's first of all go back to the clinical presentation of abdominal tuberculosis. And sometimes when we think of abdominal tuberculosis, we only think of it in terms of having ascites, particularly abdominal distension and ascites. And we forget perhaps that abdominal tuberculosis is also gastrointestinal tract tuberculosis. So it's involving the gastrointestinal tract as well as the peritoneal cavity. And many children we know with abdominal tuberculosis present with abdominal distension. That's often why they present, because the parents or they feel uncomfortable about their marked abdominal distension, and that's often because of ascites. But they often also have gastrointestinal tract abnormalities, like with chronic or persistent diarrhea or malabsorption, especially. And so, presenting with abdominal TB, we need to ask about a history of chronic or persistent diarrhea, about mucus in the stool, about blood in the stool, about abdominal pain, and examine for ascites and abdominal distension. Then there's the children that present not with abdominal symptoms, but with other features of disseminated TB. They've got extrapulmonary TB that involves their abdomen, but also other organs. And so when we are examining a child or taking a history and doing an examination on a child who's got possible abdominal TB, we need to think about the other forms of TB, tuberculosis of the pleura, or pulmonary TB, or lymph node TB in other places, or central nervous system TB, or bone and joint TB, Pott's disease, etc. So we need to think across the spectrum of presentations of disseminated TB. And then there's the children that just have present with pulmonary tuberculosis, but if you look hard enough, many children with pulmonary TB also have gastrointestinal tract changes consistent with TB on imaging. And many children who have pulmonary TB will have coughed up the tubercle bacilli into their mouth, they'll have swallowed it, and then it can infect their gastrointestinal tract. That's usually the mechanism by which children can go from just having pulmonary TB to having gastrointestinal tract TB, and also abdominal TB with ascites, etc. The other mechanism of spread, of course, is not just swallowing the infected mucus, infected sputum, but a bloodborne dissemination of Mycobacterium tuberculosis in disseminated TB or miliary TB. So each of these three different clinical scenarios, whether it's just abdominal TB, whether it's a form of disseminated TB, or whether it's just pulmonary TB, where they've got some gastrointestinal tract manifestations, has a differential diagnosis, and has each one has a unique diagnostic workup. The diagnostic workup, if you're working up a child for pulmonary TB, is a little bit different to that if you're just working up a child for abdominal TB, and it's a bit different again if you're working up a child who's got evidence of multisystem TB or disseminated TB. And so we need to think about the diagnostic workup for all of those scenarios. It always starts with a history, and it starts with a clinical examination and then investigations. The gold standard for the diagnosis of abdominal TB or gastrointestinal tract TB is histopathology. That's a bit like finding acid-fast bacilli and sputum. You know that child's got TB. And the gold standard is, well, it might be the gold standard. It's not often what we're able to achieve, because we often don't get biopsies of the omentum or lymph nodes in the gastrointestinal tract or the bowel wall itself. And of course, in those biopsies, the gold standard, you'd find granulomas, you'd find draining lymph nodes that were packed with mycobacterium or inflammatory cells, and you'd find acid-fast bacilli on Ziehl-Neelsen staining. Now, while that's the gold standard, we don't often achieve that, and so we have to be satisfied with the clinical features of abdominal TB. Increasingly, people have done GeneXpert tests on abdominal specimens. So it started with ascitic fluid, looking for, when children who have ascites, draining the ascites and seeing if that is positive for either acid-fast bacilli on Ziehl-Neelsen staining, or positive for GeneXpert, looking for the on PCR. It's a PCR test looking for DNA consistent with Mycobacterium tuberculosis. And more recently, in the last few years, people have looked at stool to see if that will be positive for Mycobacterium tuberculosis on PCR. The problem with these two methods, the GeneXpert on ascitic fluid and stool, if it's positive, it tells you the child's got abdominal TB or gastrointestinal tract TB. But if it's negative, it doesn't tell you the child doesn't have that condition, because they're relatively insensitive tests. Just like GeneXpert on respiratory secretions in children with pulmonary TB is relatively insensitive. That is, it's found positive in about a third of cases. In abdominal TB, it's a bit less, so 20% of cases in stool and about 28%, so around about the same as sputum, induced sputum in a child who's got pulmonary TB will be positive on ascitic fluid. So if you find it, it's definitely there, the child's got TB. But if you don't find it, then you have to use other clinical features and radiographic features to integrate together to make the diagnosis. But also increasingly, especially in the last 5 years, abdominal ultrasound and CT scans have been used in children who've got clinical features suggestive of abdominal TB, and they've shown to have quite a strong diagnostic yield. And that's what I wanted to talk a bit more about today. I'm just going to tell you about one study, and then we'll talk about the features. But in one study of children in South Africa who had 102 children, of which 37 children had sputum positive TB. So we knew that they had TB. And of those children, all of them had an abdominal ultrasound, and many of them had clinical features of abdominal TB. And the clinical features on ultrasound that were most specific for abdominal and gastrointestinal tract TB were lymphadenopathy and splenic micro-abscesses. So many of these children had both lymphadenopathy. 64% were positive for lymphadenopathy with multiple enlarged lymph nodes throughout the gastrointestinal tract. And many children, were about half, were positive for splenic micro-abscesses. I'll show you pictures of these features shortly. before we do that, I wanted to touch on some of the terminology that's used in ultrasound so that we can be literate about ultrasound terminology and what it means when you read a report or when you do an ultrasound yourself. First of all, this concept of echogenicity. It's a bit like density on a CT scan, but echogenicity, that's the measure of the image. It's a measure of the what produces the image on an ultrasound. And echogenicity means where the ultrasound probe is emitting sound waves, ultrasound waves, and it either passes through or hits structures, and they either reflect, that is, the sound waves bounce off the structure, or they transmit, which means they go through the structure. And the relative difference between in whether a structure, the sound waves bounce off the structure or they transmit through the structure, gives you the pictures on the ultrasound. And when you have different structures interfacing each other, then the relative degree to which they sound waves bounce off the structure or they pass through the structure or transmitted through the structure, that's what gives you the picture. And so it's a bit like on a plain X-ray, you only get images where you've got an air-solid interface, right? Where what makes the lines, the opacity on a chest X-ray is the air-solid interface, and on an ultrasound, the images are made by the differences to which ultrasound waves pass through structures within the tissues that you're scanning, or they bounce off the tissues, and again, relative to structures around them. So our bodies are made up of all different structures with different echogenicity. They will handle sound waves in different ways. I'll try to explain some of those things. So I want to now talk about that's the general concept of echogenicity, but there are broadly three types of degrees of echogenicity. From when you look at an ultrasound scan, anything that looks very black is entirely black. That's called anechoic. That means that the sound waves can't pass through it. No sound waves will pass through it. And any structure that appears black, that means that's where the ultrasound waves have not passed through it. And there aren't any internal echoes within the structure. And so water, for example, often clear-looking ascites or cysts that have just water or very clear fluid inside them, or blood vessels that or sometimes the gallbladder, if it's just fluid filled, they'll be black, and that's because there's no structures within them for the sound waves to bounce off or to be transmitted through. With water, the sound waves will not reflect back to the ultrasound probe, so there'll be no echogenicity. It'll be anechoic, an meaning absence of echoes within the structure. It's entirely black. When a structure's called hypoechoic, that means it gives off a few echoes, but not too many. A few echoes, and what it means is that it gives off fewer echoes than the structures surrounding it. So there's the structure that's hypoechoic is darker than the surrounding structures that are relatively hyperechoic. That is, those structures surrounding it give off more echoes. Whereas structures that are hyperechoic is where you've got a lot of echoes given off, and that will be more white, right? So things like fascia or muscles or calcification or scar tissue, they'll all many echoes will bounce off structures like that, and that will be more white. Whereas structures where the sound waves aren't don't reflect off, they'll be blacker. I'll explain this with some more pictures, and I try to make sense of it in terms of what you find when you're looking at abdominal ultrasounds, and how that can help us make the diagnosis of TB, for example. There are certain tissues that have a characteristic echo color. And so, for example, bone is anechoic. Sound waves don't, so sound waves tend to bounce off it, but not pass through it at all and not bounce back. So they tend to be black. Bones tend to be black with a hyperechoic rim. That is, all the sound waves go around it rather than being reflected back. As I said, water and air, they're anechoic. There's no reflected back sound waves, and so they're like cerebrospinal fluid. If you ultrasound the ventricles of a newborn baby or a baby with an open fontanelle, then the ventricles are black. The gastric bubble, usually black. The lumen of the bowel, unless it's got debris or stool inside it, that will be black. Cartilage is hypoechoic. That is, there are some sound waves bouncing back, but usually the structures around it are more echoic than the cartilage itself. Blood vessels, as I said, if they're flowing freely and there's not a clot in them, then they're anechoic. Sound waves don't bounce back. Connective tissue, where it's like scar tissue or fibrous tissue or muscle, that will have hyperechoic lines throughout it. I'll show you some pictures of that. An abscess will be hypoechoic. This is an abscess. It's hypoechoic with surrounding hyperechogenicity, and inside it there's some echogenicity within it, and that's usually debris or thick pus or something like that, other tissue within the abscess, thick pus within the abscess. So that that tissue within the abscess reflects back some echoes. Lymph nodes, for example, they're usually hypoechoic. They're usually quite black, and they sometimes, because the lymph nodes have some blood vessels inside, when you turn on the color Doppler, you often see a little bit of vascularity within them, and you sometimes have a minimum capsule around them. So lymph nodes are usually black, hypoechoic, and they have a small capsule surrounding them, and they have a little bit of vascularity. But if they're pathological, then they're either larger or they're more vascular. That is, they have more blood vessels within them, or they sometimes have a hyperechoic center with some debris inside, etc. Muscle, for example, muscle is connective tissue, and so you'll see all these striations, these hyperechoic striations within it. So that when you look at that ultrasound I've shown in the picture, it looks more like muscle, doesn't it? You can see that's muscle. So now we get on to what the abdominal findings in TB are if you do an ultrasound. And this is the typical finding where you've got large multiple lymph nodes. So this is a child who had abdominal TB, and you can see there are large hypoechoic, like black circles within the abdominal cavity, and they have a hyperechoic capsule, and it's a thickened hyperechoic capsule, and they're hypoechoic. So that's you can see 1, 2, 3, 4, 5, quite large lymph nodes, and that would be typical of abdominal lymphadenopathy, which is common in abdominal TB. If you look around the lymph nodes, you see sort of thickened hyperechoic material also, and that's often a hyperechoic mesentery, or the omentum is hyperechoic or thickened because you've got multiple layers of fibrous tissue and strands of fibrin all throughout the peritoneal cavity. That's the typical feature of abdominal TB, multiple large lymph nodes. This all again, this is abdominal TB where there's multiple large lymph nodes. They're hypoechoic. They've got a thickened hyperechoic capsule around the lymph nodes, which usually the rim is sort of granulation tissue, like scar tissue around the hypoechoic lymph nodes. Now, having said this is typical of abdominal TB, it is all the findings on ultrasound of tuberculosis in the abdomen are non-specific, and a child could have, for example, a lymphoma, or they could have a secondary malignancy of some sort with lymph node spread that could look a bit like this. So I think it's important to know that there's probably no 100% specific findings on abdominal ultrasound that tell you this child's got TB. That's why you need to integrate the history, the clinical examination, look for the pattern of abdominal TB, the microbiological test, and the ultrasound or the CT scan if you can do it. The integration of all of those things will lead you to a diagnosis. I'm not going to talk too much today about CT scans because they're less available than ultrasound, but in places where just to show you what the same picture would look like on CT scan as on an ultrasound. Here is a CT scan of a child who had abdominal TB, and you can see we talked about density when we talked about the head CT scans, and there's a hyperdense capsule surrounding a hypodense lymph node, and these are just enlarged lymph nodes in a child who's got abdominal TB. So a contrast enhancing rim of the lymph nodes around the lymph node with central hypodensity from caseous necrosis. So that's caseating necrosis of a lymph node, and it's very similar to what you see on an ultrasound, but the different terminology is that it's hypoechoic or hypodense. This is another ultrasound of a child who had abdominal TB, and you can just see, a CT scan, and this is with contrast, and you can just see the multiple lymph nodes throughout the peritoneal cavity, not so enlarged in this case, but multiple lymph nodes. Again, I won't talk too much about CT scans. I said that to start with, there are some specific features, a bit more specific features of abdominal TB, one being multiple lymphadenopathy within the peritoneal cavity, and the second one being splenic lesions on abdominal TB. And the sort of splenic lesions that you can get vary from multiple hypoechoic lesions, that is black lesions within the spleen. And so here you can see multiple hypoechoic lesions. You see the black lesions all throughout here. These are not blood vessels. This is abnormal hypoechogenicity, just multiple hypoechoic lesions. That's typical of abdominal TB, but it can be due to other things, splenic infarcts or splenic secondary malignancies. This is a CT of what you can see on the ultrasound, and you can see here that firstly, it's a very enlarged spleen. The spleen is not normally as big as the liver, but in this case, it's a very enlarged spleen. And there are multiple lesions, a mixture of hyperdensity and hypodensity. And this is a child who had abdominal tuberculosis involving the spleen as well. So a miliary form of TB involving the spleen. Sometimes the lesions are not hypoechoic, but they're hyperechoic. This is another child who had granulation or multiple granulomas within the spleen related to abdominal TB. And again, you can see the splenic tissue doesn't look homogeneous. There are multiple hyperechoic lesions within a large spleen. So typically an enlarged spleen with multiple hyperechoic or hypoechoic lesions throughout. They're different where the echogenicity depends on whether it's whether they're sort of more chronic granulomas or they're or more acute changes. Sometimes this is the liver in a child who had abdominal TB, and sometimes you'll see hypodense lesions like this. This is, again, a bit non-specific for um, uh, uh, TB involving the tuberculosis involving the liver, but it is typical, although it can be seen with fungal infections in immunocompromised hosts. It can be seen with secondary malignancies such as lymphoma or other malignancies. But what you see, there's a characteristic pattern of a hypodensity with a hyperdense center. And again, the caseating granulomas give you the hyperdense center, and the inflammation gives you the inflammation, and edema gives you the hypodensity surrounding. That is seen in very advanced disseminated tuberculosis on a liver CT scan. But as I said, it can also be seen, this what's called a bullseye pattern, or wheel within wheel, sometimes it's called, can be seen in other pathology. So again, non-specific, and it has to be integrated between history, clinical examination, and imaging and microbiological examination. If you ever see this in the liver on ultrasound or on CT scan, then always look at the spleen and the kidneys and other structures within the abdominal cavity, and look for characteristic features of TB, such as multiple lymph nodes or splenic abscesses as well. The third cardinal feature, I would say, of abdominal TB is, well, what we said: one, multiple lymphadenopathy; two, splenic multiple splenic lesions; and three, thickened mesentery and omentum and ascites. And so what you see on a ultrasound when in a child who's got established abdominal TB is they'll have ascites, but it's not clear, usually not clear ascites. There's usually strands of connective tissue and inflammatory infiltrate, and it's what we call complex. It's complex ascites, not a simple ascite. A simple ascites would be just clear fluid. A complex ascites often has lots of echoes within it, and that just reflects the multiple strands or layers of tissue, the thickened omentum or the thickened bowel wall that you typically see in abdominal TB, often with draining and adjacent lymph nodes that are enlarged because of that. So here you see this is sort of normal muscle, but below that you can see how thick the omentum is, and multiple layers of thickened multi-echogenic structures. Complex, as I said. This is a normal CT scan of a 3-year-old child, and this is the CT scan of a similar age child who had abdominal TB. And all I really want you to see is how on this scan, this is a non-contrast scan and this is a contrast scan, so they're a bit different. But you can see that there's the omentum is not so thick. There's the bowel itself not contrast enhanced. There's the bone, the spine, and the pelvis, and there's the gas within the bowel. But in this scan, all of the space in between is all thick, and it's the equivalent of what you see on an ultrasound, which is just multiple layers of hyperechogenicity reflecting the thickened omentum and mesentery and the inflammatory infiltrate and the strands of fibrin within the ascites. That's typically what you see in abdominal TB, involving pretty much all the abdominal compartment. So, yeah. Okay. that's most of what I wanted to talk about today, to try to explain, to start with some of the terminology of ultrasound, so we can build up, I think, an understanding of ultrasound, both when we're reading reports and also when we are learning to do ultrasound ourselves. And to explain some of the features, I think ultrasound is particularly useful for some pathologies within tuberculosis, and abdominal TB is probably the most useful. Of course, pericardial TB, it's also a useful modality of investigation. But just to remember that all ultrasound, even though it's very useful, it really just augments our clinical examination, and the findings are non-specific. When we see these sort of changes, whether it's lymphadenopathy or splenic micro-abscesses or stranding ascites, like complex stranding ascites or mesenteric thickening, they're the 4 cardinal features. If you see those features, then you need to think, well, what else is the differential diagnosis of those changes, and do they fit with the clinical picture, or do they more fit with tuberculosis? And if a child's just got one of them, like they've just got lymphadenopathy or they've just got some ascites, then that's not as strong as if they've got all 4. And that's why if you're building up a diagnosis of tuberculosis, abdominal TB, then the more features they have, or the more extensive they are, the more likely it is that the child's got tuberculosis. But always think of what the differential diagnosis of each one of those is as well. Remember, although we think of these days of GeneXpert testing being, an important modality of investigation, it is important. If it's positive, it's very helpful. If it's negative, it doesn't mean that the child doesn't have tuberculosis. So the yield, the sensitivity is actually quite low, 20% from stool and 28% from ascites from several studies. So I think, just to summarize, I think abdominal ultrasound can strongly augment, it can add to the clinical diagnosis of tuberculosis. And in children with pulmonary TB, I think it's quite useful to do an abdominal ultrasound just to see if they've got any ultrasound features of abdominal TB, because that can have an implication for whether the child's just got pulmonary TB or they've got pulmonary and extrapulmonary TB, and that can have implications for their risk, the duration of their therapy, their risk of multi-drug resistant TB, their likelihood of having ongoing chronic malnutrition or malabsorption, etc. So it is useful. Remember, I showed that study from South Africa at the start, where quite a high proportion of children that just had pulmonary symptoms also had abdominal findings on their abdominal ultrasound. And that's especially the case if a child's got HIV. They're much more likely, if they've got HIV, TB co-infection, they're more likely to have abdominal features on their ultrasound. And especially those splenic micro-abscesses are not always, but more likely to be a feature of HIV-related abdominal TB. So that's all I wanted to say today. I know it's a bit specialised to be talking about abdominal TB and ultrasound, particularly diagnosis of abdominal TB, but I wanted to try to introduce the concept of ultrasound findings and the terminology of ultrasound, because I think throughout pediatric training, we can all learn how to do ultrasounds and what they mean. And I've only talked about abdominal ultrasounds today and abdominal TB, but there's many different ways in which we can use ultrasound to help us. And it's a tool that is increasingly available. It's very safe. It doesn't cause any harm to the patients, and it can add a lot to our. It only adds to the clinical process. So that's all I want to say today, and it's been a short talk, but I hope that's been useful for you today. Happy to answer any questions or to hear any of your comments on how you use ultrasound in your hospitals, or how you've used it. But I think we can slowly build up a bit of training on ultrasound throughout the program, and I hope that we can do that in the coming years. All right, thanks everyone. I'll stop now, and if there's any questions, please ask them. Yeah.